Welcome to online anesthesia video of the week. This week topic is anesthesia for spine surgery presented by Dr.Meenu Chadha, a senior consultant anesthesiologist and pain physician, head of department, CHL Hospital, Indore, Madhya Pradesh. She was active in lot of webinars and teaching during COVID pandemic. She has published many articles in reputed journals. She had served as president in ISA Madhya Pradesh state during 2019 to 2021.
Anesthesia for spine surgery. Now the lecture objectives for this talk would be introduction, the brief anatomy of spine, indications for surgery, the anesthetic concerns pre and intraoperatively, monitoring, post-operative care, complications, and pediatric spinal surgery. Now the scope of spinal surgery is considerable. Both adult and pediatric patients can come for surgery, which may be elective or emergency. Challenge for the anesthesiologist is to provide optimal surgical conditions while ensuring adequate oxygenation to the brain and spinal cord and facilitating the use of intraoperative spinal monitoring techniques. Now let us look at the anatomy of the spine. In short, the spine is composed of 24 vertebrae separated by a gel-like disc, both of which surround the spinal cord. The spine pain is usually classified by the part of the spine in which it occurs. The cervical spine, that is the neck, is composed of 7 vertebrae from C1 to C7. Thoracic spine, the upper and mid back, where the ribs attach to the spinal column, and it includes 12 vertebrae, that is T1 to T12. And the lumbar spine or the lower back is composed of 5 vertebrae from L1 to L5. Many of the spine conditions that cause pain can occur in any area of the spine. Now the indications for the surgery, they may be divided into 5 options: degenerative, traumatic, infectious, neoplastic, and spinal deformity. The degenerative condition results in breakdown of function and normal structure of the spine over a period of time, which may result in back and neck pain. These conditions are often caused by aging. The bulging disc, they are sometimes called as disc protrusions or disc herniations. SI joint dysfunction. The SI joints are located where the pelvis and the lower spine connect. And when the SI joint becomes inflamed or the cartilage wear down, it may result in dysfunction. Herniated disc, also called a slip disc, it is similar to bulging disc, but in addition to the disc protruding, the soft inside of the disc breaks through the outer covering and it can compress the nerves, resulting in pain, numbness, tingling, and weakness of the arm or the legs. Radiculopathy. Radiculopathy occurs when the nerve in the spine is compressed and nerve inflammation occurs. Spinal stenosis. This most often occurs in the neck or lower back. It is created when the spinal column narrows and which can be caused by a series of issues including an overgrown bone, herniated disc, tumors, and spinal injuries. This puts pressure on the spinal cord and nerves that travel down the spine. Spondylolisthesis. This occurs when one vertebra slips forward relative to the other vertebra. This can occur in the neck or in the lower back. Myelopathy is a condition in the neck or the mid-back in which the spinal cord is irritated or injured. Synovial cyst. A fluid-filled sac in the joint of the spine, usually in the lumbar area, that has developed as a result of arthritis may compress nerve like the herniated disc. Facetal arthropathy, it is a kind of arthritis that affects the joint that connects the vertebra. Facet arthropathy can occur when the protective cushioning between the facet joint breaks down and becomes thinner. Scoliosis. Adult onset scoliosis or degenerative scoliosis can occur slowly over time as the person ages. Now, the traumatic spine conditions are those that are related to trauma and can occur from series of events including car accidents, sports injuries, and falls. Trauma-related spine conditions typically results in sprains, fractures, and bone dislocations in the spine. Infectious spine conditions, they can occur following surgery or can spread from an infection in a different part of the body. There are certain risk factors which increase the chances of contracting an infection in the spine, like poor nutrition, immune suppression, diabetes, and certain types of cancer. Spine conditions that are caused by infection include vertebral osteomyelitis, discitis, spinal epidural abscess, and meningitis. The neoplastic spine condition, they may involve the tumors, which may be benign or cancerous, located in the spinal region, most commonly in the vertebra and spinal cord. In some cases, the tumor causes spinal cord compression and can damage the nerves located in the area of the tumor, causing neurological problem and paralysis. Now, spinal deformity. Spinal deformity condition occurs when there is an abnormal curvature of the spine. Spondylolisthesis occurs when one vertebra slips forward over the other vertebra below. Spondylolisthesis usually occurs when the top vertebra has a defect commonly known as spondylolysis. Scoliosis can be a condition that occurs in childhood or may occur later in life as a result of aging or degenerative spinal structure. Kyphosis is a forward rounding of the back that commonly occurs in older patients with osteoporosis. It may cause pain or compression fractures of the spine. Lordosis, sometimes called swayback. Lordosis is a significant inward curve of the lower back. Spinal trauma. Patients may present for surgical stabilization during the period of spinal shock, which begins immediately after the insult and may last for 3 weeks. A physiological sympathectomy occurs below the level of the spinal cord lesion, causing hypotension secondary to arteriolar and venodilatation. The transection above C3 and C5, they involve the diaphragm, so a ventilator may be required for survival. Transection above T1 cause quadriplegia and transection above L4 cause paraplegia. The most common sites are between C5 to C7 and T12 to L1 because they are the least protected and the most mobile. Autonomic dysreflexia occurs 3 to 6 weeks after the spinal cord injury, which is characterized by extreme autonomic response such as hypertension and tachycardia after stimulation of nerves below the level of spinal cord lesion. Now, scoliosis. What is scoliosis? It is a lateral curvature of the spine more than 10 degrees as measured by the Cobb's method on a standing X-ray of the thoracolumbar spine. It is classified according to the area in which it occurs. It may be cervicothoracic, thoracic, thoracolumbar, lumbar, or a combined double primary. How do you measure it? There is a Cobb's method for measuring it. First is you locate the superior and the inferior end vertebra, then draw intersecting perpendicular lines. The angle of deviation of these perpendicular lines forms straight line, which is the angle of the curve. The drawback of it is it measures the complex deformity in only 2 dimensions. Surgery is done when the Cobb's angle is more than 50 degrees in thoracic spine and 40 degrees in lumbar spine. The clinical manifestation, it can be shown when it is less than 10 degrees, there is normal curvature, so no symptoms occur. Less than 25 degrees, possible increase in pulmonary artery pressure on an echocardiogram. More than 40 degrees, a surgical intervention should be considered. More than 70 degrees, a probable significant decrease in the lung volume occurs. More than 100, dyspnea on exertion. More than 120, probable alveolar hypoventilation, which results in chronic respiratory failure. Now, the causes of scoliosis, it may be of 3 types, the neuromuscular, congenital, and idiopathic. The neuromuscular is the result of muscle imbalance and the lack of trunk control. Congenital is the result of asymmetry of the vertebra secondary to a congenital anomaly. And idiopathic, which has no definite etiology, but is the most common type, accounting to 80 to 85% of the cases. Now, what is the treatment of this scoliosis? It may be non-surgical as braces, application of traction, or plaster. Surgical may be either the posterior or anterior approach, or a combined stage procedure can be done. Now, for any spine surgery, the anesthesia involvement, it starts with the pre-anesthetic assessment. So airway difficulties are anticipated when the scoliosis involves the upper thoracic or the cervical spine, and the halo traction may also interfere with the airway. There may be a temporomandibular dysfunction or a restricted mouth opening when the patient has received a previous radiotherapy. Previous difficulty in intubation may be there. Restriction of neck movement due to disease, traction, or braces. Duchenne muscular dystrophy may result in glosser hypertrophy. There may be stability of the cervical spine. So it is essential to discuss pre-operatively the stability of the spine with the surgeon. The respiratory system, pre-operatively, the respiratory function should be assessed by a thorough history, focusing on functional impairment, physical examination, and appropriate investigation. Scoliosis causes a restrictive pulmonary deficit with a reduced vital capacity and a reduced total lung capacity. The severity depends on the kind of angle, the number of vertebrae involved, and location of curvature, and the degree of loss seen in thoracic kyphosis. Reduced vital capacity is the first manifestation mostly. Prolonged periods of hypoxemia result in pulmonary hypertension, hypercapnia, and eventual respiratory failure. Surgery is performed to slow the disease progression and prevent complications and limit the function of the respiratory muscles. The distortion of the thoracic cage makes the respiratory system less compliant, thus increasing the work of breathing. Significant displacement or rotation of the trachea or the mainstem bronchi may cause mechanical airway obstruction. In severe restricted defect, there is decrease in the inspiratory capacity and also ineffective ventilatory patterns which rely on an increase in the frequency of respiration. In infantile and juvenile, it is usually associated with true lung hypoplasia because the thoracic deformity is present during the period of rapid lung growth and development. In adolescent, there is a decrease in the total lung capacity is more likely to reflect the impaired chest wall mechanics that prevents the normal inflation of the lungs. Neuromuscular dysfunction etiology starts from early infancy when the chest wall is very compliant and the distortion of the thorax is severe. Now, what happens in neuromuscular scoliosis? There is a severe respiratory insufficiency due to weak respiratory muscles, ineffective cough, unable to clear secretions, incoordinate swallowing, impaired airway defense, impaired central respiratory drive, exaggerated respiratory depressant effect of the drugs. Patients are immobile and they retain secretions and recurrent chest infections. The cardiovascular system is less common, but it is more serious. Primarily, it occurs due to the changes in the structure of the mediastinum and secondary to the effect of the chronic respiratory insufficiency on the function of the cardiac system. Displacement or compression of the heart due to thoracic deformity may not allow an increase in the stroke volume. The minimum investigations should include an ECG and an echo to assess the left ventricular function and the normal pulmonary artery pressure. Central nervous system. A detailed neurological evaluation and documentation is important because of medico-legal issues. A full neurological assessment of the patient should be made pre-operatively. This should be documented for 3 reasons. First, in the patients undergoing cervical spine injury, the anesthetist has the responsibility to avoid further neurological deterioration during maneuvers such as tracheal intubation and patient positioning. Secondly, the muscular dystrophies may involve the bulbar muscles, increasing the risk of post-operative aspiration. Thirdly, the level of injury and the time elapsed since the insult are predictors of the physiological derangements of the cardiovascular and respiratory system which occur perioperatively. If the surgery is contemplated within 3 weeks of the injury, spinal shock may still be present. After this time, autonomic dysreflexia may occur. So the investigations can be divided into the minimum investigations which are required and the optional. In the minimum is the X-ray of the cervical spine, lateral view, chest X-ray, ABG, spirometry, ECG, echo. In the blood test, there is the CBC, clotting profile, urea, electrolytes, albumin, calcium, blood grouping, and cross-matching. In the optional investigations, there may be a CT scan, pulmonary function test, pulmonary diffusion capacity, dobutamine stress echo, thallium scintigraphy, and the liver function test. Now, the anesthetic management, pre-medication. You should avoid the use of narcotics or heavy sedation as pre-medication in the presence of pulmonary function impairment. The use of bronchodilating agents may be of value in optimizing the respiratory function pre-operatively. In patients with a high spinal cord lesion or whom fiber optic intubation is to be undertaken. Administration of anticholinergic agents such as atropine and glycopyrrolate is considered. Many patients will have risk factors which increase the risk of regurgitation and aspiration of gastric contents, such as recent opioid administration, high spinal cord injury, or recent traumatic injury. In these circumstances, it may be prudent to pre-medicate the patients with the H2 blocker or proton pump inhibitors. Some patients may also have nasogastric tubes in situ, which decrease the competence of the upper esophageal sphincter. Now, induction. The choice of induction technique, that is IV induction or inhalation, is guided primarily by the patient's condition and the consideration of the ease with which the trachea can be intubated. Pre-oxygenation is mandatory. Intravenous route is the one which is preferred in these cases. The use of succinylcholine in patients with muscular dystrophy has shown to cause cardiac arrest secondary to hyperkalemia, so it should be avoided. Use non-depolarizing neuromuscular blocking agents for intubation. Now, intubation. A decision must be made at the pre-operative assessment whether to intubate the patient awake or asleep, or whether a fiber optic laryngoscopy or a direct laryngoscopy will be required. The indications for awake intubation include the risk of delayed gastric emptying, the need to assess neurology after intubation in cases of unstable cervical spine, or in the presence of neck stabilization device such as halo traction, which prevents adequate airway maintenance in an unconscious patient. Now, whether it is direct or fiber optic laryngoscopy, there is a controversy regarding that. Direct laryngoscopy with manual inline stabilization or hard collar is an accepted means of intubation for many patients, provided this can be achieved without any neck movement. Fixed flexion deformities, which involves the upper thoracic and cervical spine, may make direct laryngoscopy impossible. These patients require the fiber optic laryngoscopy to facilitate tracheal intubation. Awake fiber optic intubation will be required in patients wearing stabilization devices such as halo vest, which make the conventional airway access impossible, and in those where the difficulty is anticipated because of anatomical reasons such as micrognathia or a limited mouth opening. Now, the surgery can be done by the anterior or posterior approach. If an anterior approach is advocated, then a double lumen tube for lung isolation to access the anterior spine is used. For posterior approaches, a single lumen tube can be used. Now, maintenance. A stable anesthetic depth is required in order that changes to somatosensory or the muscle evoked potential can be interpreted reliably. A technique involving nitrous oxide 60% and isoflurane less than 0.5 MAC is compatible with somatosensory evoked potential monitoring. Either a nitrous oxide narcotic inhalational technique or an intravenous technique may be used. Non-depolarizing neuromuscular blocking agents are used to maintain relaxation by continuous infusion and to maintain a constant depth of the block. Now, there are certain unique challenges in the spine surgery, which is the positioning, intraoperative monitoring, spinal cord injury, and the hypotensive anesthesia. Positioning, depending on the level of the spine to be operated, the position is decided. Prone position is the most common one used in mostly all spinal procedures. Supine position with the head traction can be used for the anterior approach of cervical spine. Sitting or lateral decubitus can be used occasionally. The intubation and induction is done in the supine position, and then the patient is made prone very carefully. The neck should be in neutral position. In some cases, the head may be turned to one side, but it should not exceed the patient's normal range of motion or face down on a cushion holder. The arm should be at the side or in a comfortable position forward with the elbow flexed. The chest should rest on parallel rolls or foams or special supports or frame to facilitate ventilation. Check the oral endotracheal tube, circuits, and other attachments after you make the patient prone. And again, check the breath sounds bilaterally by means of a stethoscope. Now, there are various anesthetic problems of the prone position. In the airway, the endotracheal tube, this may be kinked, especially when you do not use a flexometallic tube, or there may be dislodgement because of the secretions may occur. Edema of the upper airway may occur in prolonged cases. Arterial or venous occlusion of the upper extremity can occur when the arms are abducted too much. Kinking of the femoral vein with marked flexion of the hips. Abdominal pressure may cause an increased epidural venous pressure, which may cause increased bleeding. Pressure necrosis of the nose, ear, forehead, breast, and genitalia may occur. Monitor disconnection is very common, so monitor should be checked from time to time. In the nerves, there may be stretch or compression or trauma to the nerve. The brachial plexus may be stretched or compressed. Ulnar nerve may be compressed. Perineal nerve may be compressed. And there may be trauma to the lateral femoral cutaneous nerve, which is very superficial. Gross hyperflexion or hyperextension of the neck is to be avoided. External pressure of the eyes may cause retinal injury. Lack of lubrication or coverage of the eyes may result in corneal abrasion. Headrest may cause pressure injury of the supraorbital nerve. Excessive rotation of the neck may result in brachial plexus kinking and problems and cause kinking of the vertebral artery. The lumbar spine, the excessive lordosis may lead to neurological injury. Intraoperative monitoring. The monitoring should include the ECG, IBP, pulse oximetry, capnography, temperature, and urine output measurement. Respiratory system monitoring should always include the end tidal carbon dioxide concentration and the peak airway pressure. In major surgery, serial measurement of arterial oxygen tension are recommended. Patients with severe respiratory dysfunction as well as a result of scoliosis may have an increased alveolar arterial oxygen gradient, which may be further increased during prolonged anesthesia because of regional hypoventilation. Thermoregulation may be impaired in patients who have spinal cord lesions before the surgery, and prolonged anesthesia causes significant heat loss. So use of temperature monitoring, warming all IV fluids, and a use of warm air mattress is recommended. Spinal cord monitoring. The American Academy of Neurology has published guidelines for intraoperative monitoring, concluding considerable evidence in favor of use of monitoring as a safe and efficacious tool in clinical situations where there is significant nervous system risk, provided its limitations are appreciated. It is now considered mandatory to monitor spinal cord function for these type of procedures. The goal of monitoring is to identify disruption in nerve signals quickly so that surgical adjustment can be made before the final spinal column configuration is set. Now, there are four main methods of intraoperative monitoring. This is the ankle clonus, the Stagnera wake-up test, the SSP, that is the somatosensory evoked potential, and the muscle evoked potential. Ankle clonus test. Historically, this was the first test to be used. Clonus is repeated rhythmic movement elicited by the stretch reflex. The clonus test is usually performed during emergence, either at the end of the surgery or during a wake-up test. All muscle paralysis must be antagonized. There is only a brief period between anesthesia and wakefulness when it is possible to elicit a clonus. The foot is sharply dorsiflexed at the ankle joint. Spinal cord injury is indicated by complete absence of repeated movement at the ankle joint. Wake-up test. This was first described in 1973. It is a gross test of spinal motor function. It remains the most reliable assessment for the intact spine. A wake-up test should be planned for well in advance and discussed with the patient. The surgeon must give the anesthetist adequate warning of the need to perform the wake-up test, as the neuromuscular block must be antagonized and the plane of anesthesia has to be lightened. As the patient becomes more conscious, they are instructed first to perform an action involving muscle groups above the level of any potential cord damage, usually involving the upper limbs, for example, to grip the anesthetist's fingers. When a positive response is obtained, the patient is then instructed to move their legs, and the response to this command is noted. If the patient can move their legs, the anesthesia is deepened and the surgery is recommenced. If the patient is unable to move their legs, then a corrective measures are instituted immediately. Now, various anesthetic techniques can be used for this. It may be a volatile-based anesthesia, midazolam-based anesthesia, propofol-based anesthesia, or a remifentanil-based anesthesia. The anesthesia requirement for the wake-up test is it should be easy and rapid to institute, reliable but quickly antagonized. Wakening should be smooth, there should be no pain and no recall. The disadvantage is it requires the patient's cooperation, poses the risk to patient falling from the table and extubation, requires practice, prolongs the duration of surgery, provides information at the time of wake-up only, and does not assess the sensory pathways. Now, SSP and MEP. The goal of intraoperative monitoring of these pathways allows for continuous assessment of the entire signal transduction pathway, including the cortex, spinal cord, and peripheral nerves, and allows the surgeon to make adjustment in real time during the operation if the signals change. The SSP are elicited by stimulating electrically a mixed peripheral nerve, usually the posterior tibial, peroneal, or sural nerves, and recording the response from the electrode at distant sites cephalate to which the level at which the surgery is performed. That is, the recording electrodes can be placed at the cervical region, over the spinous process, or over the somatosensory cortex of the scalp, or they can be sited during surgery in the epidural space. The MEP is stimulating near the motor cortex and measuring the signals at the target muscles. The functional integrity of the somatosensory pathway is determined by comparing the amplitude change and latency change of the response obtained during surgery to the baseline value. A reduction in the amplitude of the response by 50% and an increase in the latency by 10% is considered significant by most workers. SSP tests only the dorsal column function and not the motor, and rarely post-operative neurological deficit is reported despite preservation of the SSP intraoperatively. Now, anesthetics and their implications on the SSP. Satisfactory monitoring of the early cortical SSP is possible at 0.5 to 1 Mac isoflurane, desflurane, or sevoflurane. Nitrous oxide potentiates the depressant effect of the volatile anesthetics. Intravenous anesthetics generally affect the SSP less than the inhaled anesthetics. Etomidate and ketamine increase the cortical SSP amplitude. Implications are eliminating the nitrous oxide improves the cortical amplitude sufficiently to make the movement more reliable. Adding etomidate, propofol, or opioid is preferable to using nitrous oxide or increasing the volatile anesthetic concentration when anesthetic depth is inadequate. If a volatile anesthetic is needed, sevoflurane permits faster SSP recovery after the acute need. It is critical to avoid sudden changes in the volatile anesthetic depth or bolus administration of intravenous anesthetic during surgical manipulations that could jeopardize the integrity of the neural pathways being monitored. The mean arterial pressure should not be allowed to decrease below 60 millimeter, as at this point the SSP are lost and the neurological ischemic injury can occur. Now, the muscle evoked potential. The monitoring techniques are subdivided according to the site of stimulation, that is the motor cortex, spinal cord, the method of stimulation, that is the electric potential or magnetic field, and the site of recording, that is the spinal cord, peripheral mixed nerve, or the muscles. Each variation of the technique has advantages and disadvantages. The principle is the same. Stimulation by whatever means cranial to the site of the surgery causes prodromic stimulation of the motor tract in the spinal cord and of the peripheral nerve and muscle caudal to the site of surgery. The motor cortex can be stimulated by electrical or magnetic means. Recorded responses are classified as myogenic or neurogenic. Myogenic responses result from some EMG activity in a muscle such as tibialis anterior in response to stimulation. Neurogenic recordings arise from the some electrical activity in a peripheral nerve or the spinal cord. Anesthetics and the MEP. Inhalational anesthetics, they suppress the myogenic MEP in a dose-dependent manner. Nitrous oxide appears to be less suppressive than other inhaled agents. Moderated doses of up to 50% nitrous oxide have been used successfully to supplement other agents during myogenic MEP monitoring. Fentanyl, etomidate, and ketamine have little or no effect on the myogenic MEP and are compatible with intraoperative recording. Benzodiazepine, barbiturates, and propofol also produce marked depression of the myogenic MEP. However, successful recordings have been obtained during propofol anesthesia by controlling the serum propofol concentration and increasing the stimuli rates. Myogenic MEPs are affected by the level of the neuromuscular block. By adjusting a continuous infusion of muscle relaxant to maintain 1 or 2 twitches in a train of 4, reliable MEP responses have been recorded. Motor stimulation can elicit movement, and this can interfere with the surgery in the absence of a neuromuscular blockade. Physiological factors such as temperature, systemic blood pressure, PaO2 and PaCO2 can alter the SSP or MEP and must be controlled during intraoperative recordings. Spinal cord injury. The neurological damage during surgery and anesthesia is not limited to the site of surgery. Paraplegia and quadriplegia have been reported as a result of poor patient positioning. Rarely, neurological damage, either at levels remote from the site of surgery or during surgery, unconnected with their spinal disease, may occur. Neurological damage is more likely at or near the site of the surgery on the spine. Now, there are various risk factors for it. It may be the length and type of the surgical procedure, spinal cord perfusion, underlying spinal pathology, or pressure on neural tissue during the surgery. Blood conservation. Now, this spine surgery is usually associated with a significant blood loss. The blood loss is usually 10 to 30 ml per kg. Keep allogenic blood transfusion to a minimum, considering the risk of allogenic blood transfusion. Now, this can be accomplished by techniques to reduce the blood loss and by autologous blood transfusions. Hypotensive anesthesia. It is an elective lowering of the arterial blood pressure. It has the advantage of minimizing the surgical blood loss, and so there is better wound visualization. The method, proper positioning can be done so there is not much abdominal pressure, which will not compress the increase the epidural venous pressure, so increase the bleeding. Administration of hypotensive drugs can be done, such as sodium nitroprusside, beta blockers, nitroglycerin, propofol, dexmedetomidine, or inhalational agents. Now, what is the safe level of hypotension? In a healthy young individual, the mean arterial pressure of 50 to 60 millimeter of mercury can be tolerated without any complication. While in chronically hypertensive patients, they have an altered autoregulation of cerebral blood flow and a reduction of mean arterial pressure more than 25% of the baseline is not tolerated. Patients with a history of transient ischemic attacks may not tolerate any decline in the cerebral perfusion. The relative contraindications are patients having predisposing illness that lessen the margin of safety for adequate organ perfusion, severe anemia, hypovolemia, atherosclerotic vascular disease, renal and hepatic insufficiency, cerebrovascular disease, or uncontrolled glaucoma. The complications which can occur is cerebral thrombosis, hemiplegia, acute tubular necrosis, massive hepatic necrosis, myocardial infarction, cardiac arrest, or blindness from retinal artery thrombosis or ischemic optic neuropathy. The injuries can be corneal abrasions, orbital edema, post-operative visual loss. Now, this is rare, but it is a devastating complication. It can result as a result of ischemic optic neuropathy, central retinal artery occlusion, or unknown diagnosis. Now, post-operative care. All these patients should be cared of in the ICU with 24-hour monitoring, intensive spirometry, and aggressive pulmonary toilet. Patients undergoing spine surgery frequently have significant comorbidities. The surgery imposes further stress of significant blood loss, prolonged anesthesia, and difficulty in acute postoperative pain management. Surgeons prefer the patient to be conscious and able to respond to commands immediately after anesthesia for early neurological assessment. It is also important that patients are able to expectorate and to comply with physiotherapy as early as possible in the post-operative period. The decision to provide post-operative ventilation should be made before the surgery commences and explained to the patient. Patient factors include the presence of a pre-existing neuromuscular disorders, severe restrictive pulmonary dysfunction with a pre-operative vital capacity less than 35% of predicted, a congenital cardiac anomaly, right ventricular failure, and obesity. The surgical factors include a prolonged procedure, surgical invasion of the thoracic cavity, and blood loss more than 30 ml per kg. Post-operative analgesia, a multimodal approach, combination of primary analgesics and regional technique is to be used. Intravenous opioid by infusion or patient-controlled devices is the mainstay of analgesia. Non-steroidal anti-inflammatory drugs can be used as an adjunct. Intrathecal opioids can be injected before the wound closure. Epidural anesthesia, however, makes the neurological assessment difficult. Intrapleural infusion of local anesthetic or opioids can be done, and in severe cases where there is significant pain, sometimes low-dose intravenous ketamine is also recommended. Now, just a few words about the pediatric spinal surgery. Children may need spinal surgery for a variety of underlying pathology, including congenital defect, primary or metastatic tumors, hematomas, abscess, trauma, arteriovenous malformations, herniated disc, and a consequence of other primary pathology. The most common disease that requires surgery on the spinal cord are neural tube defect and their associations, namely the tethered cord, diastomylia, and syringomyelia. The aim of all the spinal surgery is to correct or limit the neurological deficit. Anesthesia for spinal surgery in children must address surgical requirements for positioning and monitoring, in addition to taking into consideration the associated medical problem, age-related pathophysiology, potential of blood loss, and the potential for vascular compromise of the spinal cord. The pediatric anesthetist is presented with a spectrum of underlying pathology in children over a wide range of age and size. A percentage of children also who require spinal surgery will also have other underlying medical problems. Now, what are the anesthetic considerations for spinal surgery in pediatric? First of all, the preoperative considerations. There should be evaluation of all the organ system to pick up other congenital defects. When assessing a child for spinal surgery, it is important to adopt a holistic approach. Many children have congenital problems and may present for multiple procedures. Associated medical conditions, details of the previous medical and surgical procedures, previous anesthetic record, and details of ongoing treatment must be sought. Evaluation of the nervous system and documentation of the neurological deficit. A full preoperative assessment of the neurological deficit, especially in case of spinal injury and muscular dystrophies, helps the anesthetist to pick up the pre-existing neurological deficit and involvement of the bulbar muscles. Evaluation of the anatomical abnormalities leading to airway challenge, specific age-related anesthetic consideration, especially in neonates, awareness of the associated pathology, evaluation of the respiratory and cardiovascular status, previous anesthetic records, awareness of potential for latex allergy, psychological status, and pre-medication as appropriate. The preoperative investigation should include a full blood count, clotting profile, chest X-ray, spirometry, urea and electrolytes, liver function test, baseline arterial blood gas analysis, cervical spine imaging, and ECG and echocardiography is recommended when you're anticipating a congenital cardiac problem. The induction of anesthesia, you should consider a fiber optic aided intubation if anticipating a difficult airway or in cases of unstable spinal injury. The venous access should be secured properly. The routine monitoring includes the invasive blood pressure monitoring where it is needed, especially in where you're expecting a lot of blood loss. Now, maintenance of anesthesia. Airway maintenance is very important in these small children and securing the tube well because the tubes in small children tends to slip out. Prone position and ensuring the safety in prone position. Use of appropriate agent for anesthetic maintenance. facilitation of the spinal cord monitoring, maintenance of the spinal cord perfusion pressure, prevention of hypothermia. Premature infant and term neonates, they are particularly vulnerable to hypothermia because they have little subcutaneous fat. The hypothermic neonates, they are also more prone to apnea, bradycardia, hypotension, and acidosis. Children are more vulnerable to hypothermia because of the greater surface area to body mass ratio. Infants maintain normothermia by a combination of vasoconstriction and brown fat thermogenesis, but cannot increase their metabolic rate in response to mild intraoperative hypothermia. Over 1 year of age, non-shivering thermogenesis is replaced by shivering. Hypothermia also prolongs the recovery from the neuromuscular block, impairs the platelet function, and ultimately leads to a higher incidence of wound healing. Maintenance of volume status is very important because these children cannot tolerate fluid overload or a fluid deficit. Awareness for potential for blood loss and blood conservation technique, and antibiotic prophylaxis after discussion with the surgical team. Post-operatively, these patients should be kept in a high dependency intensive care unit where nursing is appropriate and a good post-op analgesia is recommended. So, these children may present for spinal surgery at any age from infancy to adolescent. The anesthetic management requires a meticulous approach to safety, positioning, and spinal cord perfusion with maintenance of normothermia and normovolemia. The neurological deficit can be minimized by careful attention to pre-op assessment, good surgical technique, good hemodynamic control using cardiovascular monitoring, and continuous monitoring of the spinal cord function. Thank you.